Hey guys, we are going to get started in just a few minutes. Hey guys, we're going to get started in just a few minutes. Guys, we're gonna get started in a few minutes. I'm just giving some extra time for some people to get signed in. Hey guys, again, we'll get started in just a few minutes. I'm gonna give a few more minutes for a few people to get logged in, and then we'll get started. Hey guys, Dr. Haverland here. Just a few more minutes. I'm going to let a few more people jump on our webinar today, and then we'll get going. Today, is a sensitive subject about fertility, but I do think that it's very important to talk about and to have a discussion with your doctor that's open, but that really dives into how endometriosis affects fertility. And I have many women that don't desire pregnancy or don't want to be pregnant, and I support them 100%. But I do think for the patients that want to talk about fertility or have more questions about fertility or their own personal struggles, I think that this is really important. And so when we were advertising or talking about this webinar, I was excited to talk about it, but I understand that it's also very, very difficult for a lot of patients. And so I wanted to make sure that people were aware that this was a fertility talk, and that this would be talking about specifically about how endometriosis affects fertility. And in doing so, just wanting to be cognizant of the patients that have trouble with fertility or haven't been able to achieve their goals when it comes to fertility, and also advocate for women that do desire fertility, that want some more answers about why this disease is negatively impacting their goals for pregnancy. But again, I just wanted to put that out there at the beginning of this talk, that we will be discussing fertility, and I do understand that this is a very sensitive subject. As there, I have many patients that don't want pregnancy, that they've never wanted pregnancy or wanted children, and I support that completely. Women are much more than just vessels for baby making. But I also understand that a lot of my patients do come to me for fertility advice, fertility surgery, fertility sparing type surgeries. And I work hand in hand with a lot of fertility doctors, helping patients reach their goals when it comes to fertility. But I wanted to make sure that I'm mentioning this at the beginning of this next hour, that we will be talking about fertility. And I do understand that it's a sensitive subject for many of my patients, and I want to be very cognizant about that, and respecting, and respectful of them, understanding that this can be, sensitive, and it can be a difficult discussion when it comes to fertility. So anyways, I'm just going to give a few more minutes for patients to, or people, not all patients, sometimes they're husbands and fathers and boyfriends and friends of patients, to jump on, so that we can talk about fertility and endometriosis and how they overlap. So just a few more minutes, and then we'll get started. Right. I have a few more people joining. Yeah, thank you guys for joining today. Um, all right, I think most people have joined on. We're starting just a few minutes behind. So I want to thank you guys for joining me today. Again, I want to make sure that everybody on this this webinar understands that this is going to be a fertility discussion, and understanding that sometimes fertility can be a very sensitive subject. I want to respect all of my patients, but understanding that not everybody desires fertility or everybody wants fertility. However, I do have many patients that are referred to me, for fertility management, fertility surgery. I worked hand in hand with a lot of fertility doctors. But today, for the next hour in this webinar, we will be discussing for the fertility aspect of endometriosis, and specifically the fertility aspect of endometriosis. We may kind of go off and talk about a few other aspects of endometriosis, but today, for the next hour, mostly talking about fertility. So I just want to put that out there, so that anybody that this is kind of a sensitive subject for understands that at least for this week in this hour, this is what we're going to be going over. And so today we're going to talk about how to protect and boost your fertility with endometriosis without guesswork or false hope. So many women with endometriosis are left in the dark about their fertility prospects. They're told, try sooner or just see what happens without a plan. And that leads to confusion, anxiety, and sometimes unnecessary loss of time. This webinar offers a clear understanding of how endometriosis affects fertility and the latest treatment and planning options and how to emotionally navigate this journey with confidence. By the end of this webinar, you'll know how endometriosis can affect fertility, how to proactively plan your next steps with or without surgery, and which support systems can help you emotionally and medically prepare for your fertility journey. So if you've been told you might struggle to conceive, but were never given a plan, or you've tried for months or years without answers, you're not alone, and it's not your fault. So today we are going to explain all of this without sugarcoating or scare tactics, just expert-based facts and compassionate guidance so that you can make clear decisions and not to panic. Endometriosis can be very complex and sometimes it's difficult, but today we're going to really dive into how it affects your fertility and how we can navigate that and hopefully come to better outcomes. So what if I told you that endometriosis isn't just about pain? It's one of the leading but least discussed causes of fertility. So research shows that up to 50% of women with endometriosis may experience difficulty conceiving, yet most aren't given a clear fertility plan until it's too late, and some women are never even told it may be related to endometriosis. I'm Dr. Rachael Haverland. I'm a board-certified gynecologic surgeon specializing in endometriosis and reproductive health. I've worked with hundreds of women to help preserve and enhance their fertility and to do it in a way that matches their life goals. By the end of this session, you'll know the specific ways endometriosis can affect fertility, how to plan treatment strategically, and how to take back control of your reproductive health. And if you stay until the end for the next hour, you'll get my fertility planning checklist for endometriosis, which is a step-by-step guide to help you make the most of your time and options. So the first thing we're going to talk about is how endometriosis affects fertility. I'm going to admit a few more people here. And before I forget, I would like y'all to use the chat. I want this to be as interactive as possible. I'm here talking to myself for the next hour. So the more interaction, the better. This is going to be recorded, and at least portions of it will be put up on different social media, but I'll make sure to see if we can get the whole recording and maybe put it up on YouTube. But I think that would be very beneficial. Use the chat options. Talk to me about questions. If something I'm explaining doesn't quite make sense, let me know. I want this to be as interactive as possible. I love talking about endometriosis. I love educating on endometriosis. I love advocating for endometriosis. This is I'm so blessed and honored to get to have this job. And the goal in my career is to try to treat women earlier, get women earlier diagnosis and treatment plans so that hopefully fertility isn't something that they have to navigate in the future. But really, this is one of the topics that I'm passionate about is the fertility aspect of endometriosis. And I do understand, again, that this is a sensitive topic for many people, and that I have many patients that don't desire fertility, and that's completely fine. But today, that's what we're going to talk about is endometriosis and fertility. So the first thing we're going to talk about is how endometriosis affects fertility, the real story. So there's a misconception that if I'm still young, I have plenty of time. That is absolutely false, especially with endometriosis. So endometriosis is a chronic inflammatory disease. Women with endometriosis have damage to their ovaries because they're living in an inflammatory environment. So sometimes, especially with more advanced endometriosis, your average egg quality, your average ovarian reserve, your average ovarian function is significantly less than your colleagues of the average age or of similar backgrounds. And so endometriosis can affect ovulation, it can affect egg quality, it affects pelvic anatomy and inflammation. And ultimately, anything that's living in an inflammatory environment is not going to be as high quality as it would be otherwise. And so first, let's talk about the ovaries and how they are affected by endometriosis. So the ovaries are made of ovarian stroma. So stroma is on the outside of the ovaries. That's where your follicles are made. And that's the most important part of the ovary to preserve when we're doing surgery, because the stroma, the outside of the ovary, is imperative not only to future fertility, but also for the longevity of the ovary and the functionality that the ovaries give us. But when we see this endometriosis affecting the ovaries, we notice that it can also affect the follicles. Women that have an endometrioma on their ovary, which is a cyst filled with endometriosis, tend to have significantly less quality follicles on that side. And we know that through in vitro fertilization. So when women go for an egg retrieval, ovaries that have endometriomas, those follicles in general may have a lower quality, and they tend to have a lower quality than an ovary without an endometrioma. And this is because the endometriosis is very toxic. It's very irritating. It's very inflammatory. And so when this cyst is on the ovary, not only is it taking up a large portion of the volume of the ovary, so it may make it harder to access the follicles that are there connected to the ovary tend to be less quality. We also talk about the difficulties with egg retrieval and an endometrioma, because when you do an egg retrieval, you do not want to put your needle through the endometrioma to get to the follicles, because I talked about this earlier. The endometrioma are very caustic, they're very irritating. And so if your needle goes through the endometrioma to get to the follicle will be damaged by this inflammatory tissue and has much less likelihood that it's going to be able to form an embryo and survive the next process of being able to implant down the road. And so when you see these endometriomas, you know that ovary is damaged. Subsequently, if we go in and remove an endometrioma surgically, it also damages the ovary to some degree. And so you may have higher quality follicles on that side, but it may lower the number of follicles that you have. And so it's a catch-22 between, how, if when you do your egg retrieval, how the endometrioma is affecting the ovary. It also depends on the location of the endometrioma. If you can't access the follicles because of the endometrioma and its location, it makes sense to potentially do surgery before that so that you can access the follicles on that side, or then ultimately you're only working with one ovary if you don't have an endometrioma on that side. And so, the first thing we talk about is how endometriosis affects egg quality. And again, women with endometriosis tend to have overall more damaged ovaries, less quality eggs, especially with an endometrioma, but in general, even early stage endometriosis can affect the ovaries. However, fertility in general is more related to stage when it comes to endometriosis. So women with stage 1 endometriosis, it can have debilitating pain, because stage does not correlate to symptoms, but it may correlate to how it affects your fertility. So women with stage 1 endometriosis have a better chance of being successful with fertility than women with stage 4 endometriosis, for example. And so we talked about how the ovary can be affected. One is it can decrease the quality of the eggs on that side. It also can make it more difficult to access if you're undergoing IVF. And these endometriomas, if they're on the ovaries, it causes a very caustic atmosphere. Even without an endometrioma, the ovaries and the pelvis, they live right next to each other. So in pictures and anatomy books, they look like they're up high and the uterus is in the middle, but this isn't how they are in real life. This is how they are in surgery, because we're elevating them, or how we're looking at them in an anatomy book. But in reality, they live in a small area underneath the uterus, between the uterus, the vagina, and the rectum, in the pelvic cavity. So endometriosis in any of these areas can negatively affect the ovaries, because ultimately they're living in an inflammatory environment. Anything that's living in an inflammatory environment is just not going to be as high quality as it would be otherwise. So that's how the ovaries can be affected with endometriosis. This inflammation that's surrounding the ovaries affects the ovarian quality, but also affects the ovary itself. So women with endometriosis may go through menopause at an earlier time. Their egg quality might be damaged to the point where they may have missed their window of opportunity earlier. And so that's something I talk to my patients about, that I think is very important if the patient desires fertility or something they talked about. We don't know an average age. Women now are starting to have babies later, but women with endometriosis, this can happen their ovarian function and their ovarian reserve can deplete much faster than women without endometriosis. So I think it's imperative to at least have these conversations as early as possible, if that is a goal, for you, to make sure that we try to give you all of your options going forward, and then hopefully, if fertility and pregnancy is something that you desire, that we help you meet your goals. So that's how endometriosis affects the ovary. As you all know, when this process of fertility, the egg is ovulated from the ovary, and then it's picked up by the fimbria of the fallopian tube, and it meets the sperm in the fallopian tube. There's an area of the fallopian tube that's more common for pregnancy, or for this merging of the egg and the sperm. However, endometriosis, when it is in this, around the fallopian tube, even if technically the tube is open when you do your HSGs or you flush dye through your tube and it shows that it's open, if endometriosis is around the fallopian tube, living again in this inflammatory environment, because all the ovaries and fallopian tubes live in an area that's very small between the uterus and the rectum in this pelvic cavity, endometriosis in any of these areas can negatively affect the tube. And so with this inflammatory environment, it can make it harder for the egg and the sperm to fertilize. And then in doing so, it can also make it harder for the egg and the sperm to travel through the fallopian tube and then implant into the uterus. And so endometriosis can affect so many areas of this initial process of implantation and fertilization. And it's because of this inflammatory environment. And so our goals when we treat endometriosis is to improve the environment of the pelvis, improve these aspects that endometriosis is negatively affecting, so that we can get better outcomes. Some of this is surgery by excising the endometriosis, removing the root cause. Some of this is improving your inflammation with diet and exercise. But endometriosis negatively affects fertility in a large quantity of women. And in fact, it's the most common cause of, quote, unexplained infertility. And I think that that's incredibly important. So many women have been told over and over again that their fertility journey is unexplained, but it is not unexplained unless you've ruled out endometriosis, because it is the most common cause of unexplained endometriosis, because typically this is the underlying cause. But if you don't look for it, you don't know, and you miss it. And I talk to my colleagues about this. I talk to my patients about this. It is important. It is so frustrating to not get answers. But women that have symptoms of endometriosis, painful periods, painful intercourse, painful bowel movements, bladder irritation, alternating constipation and diarrhea, feeling like you have a UTI, or even there's silent endometriosis. I have plenty of women who are completely asymptomatic, but undergoing this fertility journey. We've done a laparoscopy found pathology-proven endometriosis. So unless you look, you don't know. And it is not unexplained until endometriosis has been ruled out by an expert, not somebody that just goes in and looks at the camera for 5 minutes, but doesn't really know what they're looking for, or doesn't dissect out the tissues or send some to pathology. You're missing the boat. And it is very important to understand the etiology behind your fertility journey or the infertility journey, the difficulty getting pregnant, so that you can treat it appropriately. And rather that's surgically, rather that's with hormones, rather that's with increased estrogen or decreased progesterone. It all depends. Everyone is very individualized, but it is imperative to try to find the root cause so that we can treat the problem, and that way we can give better outcomes. And so, I had a patient in her late 20s. She talked to me, and she's like, came into my office as an initial consult. She said, I can wait, I want to wait until at least I'm 35 until I get until I'm working on pregnancy. I have a career in front of me, and I don't have a spouse yet. When we went in for surgery, there was, severe inflammation. And we got some lab tests, and her ovarian reserve had already been significantly impacted, even at age 20. There's not an age cutoff for endometriosis. You can't say, oh, women with endometriosis should get pregnant before 30. That's just not true, because everybody is so different, and endometriosis affects ovaries and egg quality in a different way. So my goal in my career is to try to treat women earlier and diagnose them earlier with endometriosis, because even one patient, if I can catch them earlier and treat them earlier, and they have a more of a benefit, a better outcome if they do have these options of fertility, whereas maybe if they waited, you know, 5, 10 more years, they wouldn't have had these options. But it's imperative to evaluate, to know where you are you standing. So most of my patients I offer to meet with a fertility doctor. Hey, what does my fertility look like? What are my options of getting pregnant? What are my chances of getting pregnant? I always offer to send them to a fertility doctor because that's your true workup. You get different lab values. They do a follicular count. They're looking at to see if your tubes are open. They're giving you more of a full picture because there's not just one statistic or like one data point that's going to tell you your likelihood of getting pregnant. And this is also not evaluating the sperm at all. This is only evaluating you and your anatomy and your ovarian reserve. And so, understanding how endometriosis impacts fertility now allows you to act before time becomes a limiting factor. And it is very important. Again, endometriosis is a main disease. It affects women in so many ways. It doesn't follow the rules. One of the ways that I see it affect patients in just a debilitating way outside of pain is how it affects their fertility and sort of steals that from them before it's before they know that they no longer have options, or it's very much of an uphill battle. And endometriosis, the way that it causes this chronic inflammation in this caustic environment, really, debilitates and affects the environment of the pelvis, and in doing so, negatively affects all of these steps that are imperative with a pregnancy or implantation of an embryo. And so again, thank you guys for kind of sticking this out with me. I'm admitting a few people as we're going through. Use the group chat as you like. I would love to interact with you and talk about this. In the chat, there is a link. So in this link, you can click on it and use the calendar to meet with my scheduler. So this is not an immediate visit with me. This is a meeting to meet with my scheduler to get on the books to have a visit with me. But on this link, you can click on it and then you'll meet with my scheduler. You'll give her your insurance information and she'll kind of talk you through surgery scheduling or sort of scheduling a visit with me, sort of what that looks like. But I would love for you to use this link in the chat if you'd like to schedule a visit with me. But just remember, this link is not a direct visit with me. This is a visit with my front office staff, who will then get you on the books to schedule with me. It's kind of a process, but it's important to go through it so that way we can get all of your information ahead of time. Ask you the questionnaires and such. So I remember to use this link to meet with my front office staff, and at that appointment time, you'll meet with my front office staff, and then ultimately get a visit scheduled with me. And I'll again discuss this again later in the webinar. And so, just going through some of the questions, if somebody's struggling with fertility and has endometriomas, would you consider removing them? And I think this is all. It is a difficult decision, and I think it depends on where you are in your fertility journey and what the other data points look like. Endometriomas, like I talked about, negatively affect the ovaries. They can make the quality of the eggs that you make from that ovary might be not as high grade or high quality. Might make it harder for your fertility doctor, if you're undergoing IVF, to retrieve the eggs on this ovary. If they are smaller endometriomas, you might be able to retrieve the eggs without a problem, but depending on the location and where the endometriomas are, it might be harder to retrieve the eggs from the ovary because they're affected by the endometriosis. And so, as a surgeon, I always remove endometriomas. I feel very strongly that the endometrioma and the cyst wall of the endometrioma should be removed so that it doesn't recur. It can, in doing so, improve the egg quality and potentially preserve the ovaries for longevity. However, with that being said, every time you do remove an endometrioma, there will be some damage to that ovary. No matter how you do it, the technique that you use, there will be some damage to that ovary. And so that's really important to talk about. What is your starting AMH? What is your starting ovarian reserve? Have you been able to get pregnant before? I mean, there's a lot of different data points that I think are really important in this discussion. Would you consider doing IVF? Is IVF something that you don't feel comfortable with, that you would never want to do? Would you like to try naturally first? Are you already in the process of going through IVF? And there's a lot of moving parts when it comes to fertility because it's not super black and white. But I do feel very strongly that before trying, before embryo implantation, if you haven't been successfully pregnant for, 6 months to a year, that we should go in and remove the endometriosis, which includes the endometriomas. Now, I always talk to my patients about this discussion of, would you like to meet with a fertility doctor first? Would you like to talk about your ovarian reserve or your AMH, how they think that this endometrioma, based on location, based on size, will negatively affect your fertility going forward, at least as far as your follicles on that side. But it's very important to have these discussions and have somebody bring it up. Again, endometriosis is the most common cause of unexplained infertility, and so we know that it is very, very common, especially in the fertility world. And it is not unexplained sorry, got tongue tied. This is not unexplained infertility until endometriosis has been ruled out. Again, as it is the most common cause of unexplained infertility. So, the next kind of topic that I want to talk about is treatment and fertility planning options that work. So there's a misconception that surgery or IVF are my only choices with endometriosis and the fact that I have endometriosis. So there are treatment pathways, and that does include excision surgery, and we'll talk about that. Hormonal management. You can also work on timed intercourse, IUI, which is intrauterine insemination. As long as the fallopian tubes are functional, you can do IVF. If you don't have a partner, you can also do egg freezing. And you have to decide what's best for you, because again, this is not a one size fits all. I meet with young women from age 15 to 52 that still desire pregnancy, that still desire future fertility. Rather they have embryos, rather they're doing this naturally, rather they're young, but they definitely want to, have this option for them down the road. And it is imperative that somebody talks to them about the potential negative effects of endometriosis and how it can negatively affect fertility. And it doesn't mean that it always will. I have women with endometriosis get pregnant naturally all the time, and that is such a blessing. After excision surgery, I see women, exponentially improve their chances of pregnancy. I don't always post these positive feedbacks because I also know that it can be a trigger for some women, and it's a very sensitive subject. But I always ask my patients, when you get pregnant, please text me. Please let me know, because it is so rewarding to see this outcome when a couple has struggled for so long, getting no answers, being told that their fertility is unexplained. And then we go in and we find the answers. We know that, hey, this was the problem. And now the anatomy has been restored. The inflammation has been decreased. We removed the endometriosis or the cysts that were, causing the endometriomas, negatively affecting the ovaries, flush the tubes, make sure the tubes are open. And now you see the benefit. And that is just incredible. It truly, makes my day. So I'm very thankful for my patients. And the process of fertility, I understand, is very complex and very difficult, but I'm very honored and blessed when patients are able to share with me their positive outcomes. All right, so I have a lot of patients that are desiring fertility, and different doctors and different specialties may have different opinions. But we know that endometriosis causes this inflammatory environment, and therefore anything in this inflammatory environment is not going to be as quality, including your egg quality, including the ability of the egg and the sperm to fertilize in the fallopian tube, and then early implantation. So I have many women that were advised to jump straight to IVF. Like if we think you have endometriosis, we don't need to check for it. We just need to move towards IVF. But after a targeted excision surgery and a few months of healing, she conceived naturally. There's great studies actually with endometriosis excision. This is not ablation or burning the endometriosis, but with endometriosis excision surgery, by removing the underlying etiology of this inflammatory cells, by restoring anatomy, essentially optimizing the pelvis by decreasing this inflammation. Studies have showed consistently the next 6 to 9 months you have better chances of conception, both with natural fertility and also through IVF, because it is improving this environment. So your egg quality is higher. The fallopian tubes may function better. You have better chances of early implantation. Essentially, this environment is improved so that everything has a better chance of being successful. So like I mentioned before, the right plan is not a one size fits all. It's about matching the proper treatment to your timeline, goals, and health. And this is different for every person. This might be, different for my 25-year-old patient that doesn't have a long-term partner, but that wants to freeze her eggs, understanding that endometriosis may negatively affect her fertility more so, than someone else, or desiring to implement other lifestyle changes, decreasing the inflammation in other ways. Now, it doesn't make the endometriosis specifically go away, but it may help treat the inflammation, which also can negatively affect fertility, whether it's through diet, physical therapy, exercise, other ways to help manage, your overall inflammation, and your overall health can also be very important. However, we never want to let the endometriosis just grow. And it is imperative to diagnose and to treat endometriosis as early as we can. And this is through excision surgery. And again, not everyone has to have excision. I do have some patients that are able to get pregnant naturally without having, excision surgery. Sometimes they're on the books and they text me and they're like, "Hey doc, we got to cancel. We got a positive pregnancy test." And that's amazing. I am so, excited for you. Because fertility is not super black and white, but excision surgery has shown a lot of benefit in removing the underlying etiology and removing the underlying problem, and in doing so, in improving the environment of the pelvis, and therefore having higher quality eggs, better chances of fertilization, better chances of implantation, by excising and removing all of the abnormal cells so that you have better chances of success. I today we're talking mostly about fertility, but removing this endometriosis also improves the longevity of the ovaries. The ovaries give us so much benefit. They protect our bones. They protect our heart. There's cognitive benefits from our ovaries by producing the hormones and the estrogen. And by excising the endometriosis around the ovaries, in the ovaries, around the body, this is improving the environment of these ovaries and therefore allowing them to function better and for longer periods of time. And so even outside of fertility, although that's what we're talking today, you still have benefits of treating the endometriosis by preserving the ovarian function. For long term, because the ovaries and the natural hormones that we produce have so much benefit for us in the long term. Here we go. All right, we're going to answer a few more questions here in the chat. Feel free to send some questions over if you'd like. I would love for this to be interactive. Sometimes I get talking and I forget to look in the chat, but I certainly will. Let's see. I was told I have endo stage 1, and I've gone through 3 failed IVF treatments, 1 ectopic, no heartbeat. How fast the stages progress? Could this be affecting my success? So, first of all, I'm so sorry. I'm so sorry for your loss and this journey that you've had to kind of undergo over the last few years. Fertility is not easy. It is exhausting, both physically and emotionally. And if you've had an ectopic pregnancy, that's likely telling me there's some sort of damage in your fallopian tube. You have a higher risk of having damage in the other fallopian tube as well, because whatever negatively affected that one tube may affect the other tube. Then it also is if you have had a true excision surgery, if that has been, if all endometriosis has been removed, and then also importantly, what your follicular count is, what do your ovaries look like, what is your AMH, how many eggs are they able to get out when they do your IVF cycles? And do you need to do a slightly different regimen for your IVF cycles? Like, are you triggering too soon? Do they need to do like a less invasive protocol to try to get better quality embryos? Did you use Lupron? There's a lot of different moving parts when it comes to fertility and IVF, but I think those are good questions, to ask your fertility doctor or an endometriosis surgeon. Most endometriosis surgeons feel very comfortable in this space. I would say about half of my patients are fertility patients. The other half are pelvic pain. But I do get a large amount of fertility referrals related to endometriosis because we know that endometriosis, again, is the most common cause of unexplained infertility. And it is not unexplained until you have ruled out endometriosis because, again, it is the most common cause. And so it is imperative to evaluate for endometriosis and treat for endometriosis and try to do this as early as possible. There's not an exact age in which your fertility declines. There's certainly average ages, but that doesn't mean that that's how it's going to be for you. Some women, their ovarian reserve tanks at 35, sometimes it's 30, especially with endometriosis. It may happen earlier. I even see young women in their like 20s that may have this. And so it's important to be evaluated as early as you can, not only for endometriosis, but just for fertility options if that's something that's a goal for you. And you can do that through your general OBGYN, you can do that through a fertility doctor, but it's important to ask for that and advocate for yourself. Even if you're not trying to get pregnant right now, I want to know what it looks like for me. What are this snapshot in time, what does my chances look like? And the difficult part is it doesn't necessarily tell you how your chances will be in 5 years, but it can tell you where you are now and at least give you a little bit more information. Let's see. So briefly, I want to talk about how adenomyosis may be affecting fertility as well. So mostly we're going to talk about endometriosis during this, next 45 minutes. However, adenomyosis can also affect fertility. So adenomyosis, for those of you that don't know, it's very common with endometriosis. At least 30% of women with endometriosis also have adenomyosis. And I've actually been seeing it more frequently on my surgeries for whatever reason. So that percentage may actually be skewed. It may actually be much higher. Adenomyosis is inflammation of the uterus itself. The lining of the uterus kind of grows into the muscle wall. The uterus becomes heavy, boggy, inflamed. Essentially, these adenomyosis cells secrete fluid and then they get stuck in the uterus because they're not able to be excreted through the cervix. And these little lakes of fluid can cause quite a bit of inflammation. They cause pain, they cause heavy bleeding, prolonged bleeding, pain that radiates to your back, down your legs. Sometimes similar to how endometriosis affects you, but adenomyosis can affect implantation. There we don't I don't know exactly a number because while there's not stages of adenomyosis, I certainly see the differences. Like some women have very mild adenomyosis. Sometimes I go in for surgery and I'm like, this is the worst adenomyosis I've ever seen. Like the uterus is soft like a sponge. I can see dark areas. I can see light areas. This is definitely a more advanced adenomyosis, even though technically there's not stages of adenomyosis. The more adenomyosis that's in the uterus, theoretically, may make it harder or more difficult for implantation. Now, if you're going through IVF, a lot of times they will recommend Lupron before doing a transfer because the Lupron will help suppress some of the adenomyosis cells and therefore improve your chances of implantation. Now, Lupron is a very intimidating drug for many reasons. And I've actually never prescribed Lupron in my practice because I think that there's better medications. However, in the right setting for in vitro fertilization, it may be something to consider because adenomyosis does respond well to hormones. Endometriosis does not. It follows its own. It definitely does. It doesn't always follow the rules. So endometriosis may not respond or frequently doesn't. However, adenomyosis can respond to hormones. And there's pretty good data that using Lupron in patients with adenomyosis prior to transfer improves outcomes and statistically improves chances of successful pregnancy. And I understand that, these medications have side effects, and I'm not saying that you have to do it, but there is decent evidence behind that showing that with adenomyosis, by suppressing the adenomyosis immediately prior to transfer, you have better outcomes. And so that's another reason that it's important to evaluate for the adenomyosis if you're undergoing IVF. If you're not doing IVF, you can try to do progesterone in your luteal phase, which is the time from ovulation up until when your cycle starts, to try to improve those chances. All right, let's see. I may have missed this. Are you located in Texas? Yes, I'm located in Texas. I am in the DFW area. I have an office in Plano and an office in Dallas. I operate in Central Dallas, but I also do quite a bit of telehealth. Outside of the state, outside of this county. And so if it's difficult for you to be able to access care, or we aren't close to you, we'd be happy to meet with you with a telehealth. And again, I want to talk about the link in our chat. So if you'd like to schedule a visit with me, you can click the link on the chat. This link is going to set you up with my office manager. So she's going to set you up with my front office staff. At this meeting, you will meet with her. You will give her your insurance information. She will talk to you about scheduling, and then she'll put you on my book. So I just want to clarify that this link is not to schedule a visit directly with me. This visit will be with my office manager, with my front office staff, and then you will schedule a visit with me at that time. You're going to also, welcome to call the office to schedule, or you can use this link where you'll have a scheduled time with my front office staff. They'll get your information, and then they'll put down on the books to see me. And I am very much looking forward to it. Okay, now getting back to endometriosis and fertility. So, the third kind of insight is navigating the emotional and relationship side of fertility. So if I stay positive, I can get through it. Let me tell you, fertility and pelvic pain are one of the most difficult aspects of a woman's life. This is a marathon. Sometimes people feel hopeless. They feel like they're doing everything right and they're not seeing improvement. And so the emotional toll of fertility struggles, it can affect your relationships, and it may make you feel isolated. I think that it's incredibly important to try to have a support system, a support staff, people that understand what you're going through. I for one, see patients frequently struggling with this. And the first thing that I do is I, acknowledge that this is difficult. I acknowledge that fertility is a very difficult journey. It affects you emotionally, it affects you physically. And even if you're doing everything right, there's no guarantee that it's going to work. And it is so infuriating, especially when you're in a world where everybody shares their pregnancy stories. And I'm very happy for them, of course, when they do. Or people that weren't even trying to get pregnant, they get pregnant, without struggling, whereas you've been struggling for years. And I understand that it's tough. It's very important to have a good social support system, whether it's your friends, whether it's your family, whether it's your spouse. Sometimes your spouse even has a hard time understanding where you're coming from, because they're not the ones that are getting poked and prodded all the time, that are, seeing their period come when they were just hoping that it wouldn't. They're not the ones that are having to do all the fertility testing and ovulation kits, and it's exhausting. Endometriosis causes pain. Women with endometriosis have, higher risk of having, mental health side effects. When you're in pain all the time, it's also almost impossible not to be depressed or anxious. When you start to feel this pain, exacerbating it worse, how are you not anxious about knowing, like, when is it going to stop? Is this going to get to a 10? Am I going to need to go to the ER? Is this going to be just a day where it's like a 6 or 7 and I can function for the most part? But endometriosis is quite debilitating, but especially emotionally. And so it's very important to have a good social circle. one couple nearly gave up trying until they got counseling and joined a support group. And it completely changed how they approach the journey together. There's actually specific counseling for couples and individuals that are undergoing infertility. And I think that is a very underutilized resource. This is complex. It is frustrating. It is physically exhausting, but it also sometimes makes you feel very isolated. And that's because this fertility journey is not something we talk about, openly. And I mentioned that at the beginning of this webinar and kind of shouted it from the rooftops. Today, we are talking about fertility. I wanted to make sure that anyone on this webinar understood that this is a delicate subject. It can be triggering for some women. I wanted them to know that if they weren't ready to talk about endometriosis and how it affected fertility, that maybe they don't listen, or they listen to a review if they wanted to. And I have many women or many patients that don't desire fertility in the future, but it was really important for me to make sure that I stated what we were going to be discussing today. So if anybody, you know, was having a hard time, with this fertility journey, understood that this is what we're going to be discussing, and to make sure that hopefully wasn't triggering or difficult for them. So your emotional well-being is just as important as your medical plan, and you do not have to carry this alone. It is imperative to find support. I feel like I'm a good listener to my patients. I also understand that it can be hard sometimes to share some of the struggles and the frustrations. So there are support groups on social media, which I think are incredible. You can see an extensive amount of resources and options for patients in this way, and also talk to other people that are kind of going through the same traversing, the same areas that you are, trying to figure out, fertility, what's negatively affecting their fertility, and trying to achieve the same goal. And so through this last hour, now you know exactly how endometriosis can affect fertility and what options are available. But even with this knowledge, it's easy to feel lost, where to start and what to do first. So can I share a way we can guide you step by step through your fertility journey, and a plan that's just built for you? So when patients come to see me, one of the first questions I ask is, what are your fertility goals? What is your family planning journey? And so patients that do desire future fertility, we talk about this. We dive right in. So a fertility planning and support package through the Endometriosis Center of Excellence. So first, we do a personalized fertility assessment, review your history, current health, fertility goals. Have you met with a fertility doctor? What is your ovarian reserve? What do your fallopian tubes look like? Do you know? Do you not know? If we don't know, we can certainly work together to find out. And then we have a treatment pathway map. So a detailed outline of medical and lifestyle steps to maximize your fertility potential. And we talked about this. Some of this is diet, sometimes it is exercise, acupuncture, pelvic floor physical therapy. Sometimes it's related to hormones. Sometimes we talk about surgical excision surgery, but it's important to know all of your options. And most of the time we implement kind of the whole multidisciplinary plan in order to get the best outcomes. Next, an emotional and relationship support toolkit, access to counseling, support groups, stress management resources. Some of these are found online. Some of these are found through specific counselors, but it's imperative. It is imperative to feel supported as you're undergoing, through this. There's a quarterly progress review, check in, see how you're feeling, see what progress you've made, see what doctors you've met with, see what your goals of next steps. If you don't feel more confident and clear about your next steps after meeting with me, after meeting with our consult, it's 100% refundable. I want you to feel like you're listened to, feel like you're heard, feel like we're making a plan, together. Endometriosis is a very difficult disease because, I mentioned earlier that some women with endometriosis can still get pregnant naturally, without really intervention. Other women, even with early stage endometriosis, their ovaries can be affected, or it can affect their fallopian tubes, and it can make the process much more difficult. IVF in a way tries to circumvent the endometriosis, but it's not a guarantee, especially if you have more advanced endometriosis. The fallopian tubes can be affected, and and if the fallopian tubes are affected, it can negatively affect implantation. It can affect the quality of the eggs on the ovaries. And so it's not perfectly black and white. And that's another reason why endometriosis is so complex. All I do in my office is taking care of women with endometriosis, and I'm still surprised with how it acts, what symptoms it can cause, and then also what it looks like, at time of surgery. Sometimes it correlates exactly where patient's pain is. Sometimes it doesn't. Again, even early stage endometriosis can affect fertility. It doesn't mean that it will, but it can. I have women with advanced stage 4 endometriosis after surgery are able to get pregnant naturally, but it's not a guarantee. And so it's really important to work together to try to find a plan that's best for you. What are your goals? What does it look like? What is your timeline? What type of evaluations have you had? What is potentially beneficial for you going forward? Would you going forward, do you conceive before or after surgery? Those are certainly great questions. Just discussing hormone treatment. Does it affect fertility going forward? There's a lot of very important questions. And this is a question actually I see here in the chat is, should I try to conceive before or after surgery? That's that's a very difficult question. I mentioned before that I do have patients that get pregnant naturally, even being scheduled for surgery, and I'm so impressed with them. I think that is great. After surgery, your chances of natural conception improve pretty significantly, at least for the next 6 to 9 months. We flush your tubes. We look inside the uterus to make sure the uterus is perfect and smooth with an operative hysteroscopy. We excise and remove the endometriosis from the pelvis, scar tissue, inflammatory tissue, all of it is removed. So the environment of the pelvis is improved. It doesn't mean, though, that you should wait for surgery until you're ready for pregnancy, because the earlier we can treat the endometriosis, the better chance that it doesn't continue to grow and negatively affect that fertility. So that's the caveat. If we know you have endometriosis, and when you feel ready, we should do surgery for excision and then implement the other lifestyle changes going forward. However, if you're in this active process of you've tried for a year or 2 years and you're not being successful after surgery, you do see that benefit for the next 6 to 9 months after surgery. And at least that's what the statistics show. How long should I try naturally before getting help? So this is different for your age. So if you've tried naturally for 6 months before age 30, after age 35, then you should get an evaluation from a fertility doctor. If it is after or before age 35 and you tried for a year, then that is statistically when you should get help. However, women with endometriosis, again, are affected more. They're affected more with fertility. If we know you have endometriosis, and you haven't tried for pregnancy before, I would try for a few months, but ultimately it is never the wrong time to get an evaluation. I always recommend getting a fertility evaluation earlier, because women with endometriosis are affected differently. Their ovarian reserve may be lower. Their ovaries may not function as well. They may have higher risk of lower AMH or ovarian reserve because the endometriosis has affected those cells and the stroma around the ovaries. So theoretically, it's 6 months after age 35, 1 year with age before 35. But I would strongly recommend, if you know you have endometriosis, not to wait to get an evaluation as soon as you know. Lastly, when should I consider freezing my eggs? That's another question in the Zoom, which I think is a great question. There's not an exact age at which you should consider freezing your eggs. Ultimately, the earlier the better. Statistically, you need 10 to 13 eggs that are high quality in order to get one embryo. And so eggs do not freeze as well as embryos, or they don't function as well. There's just a process of thawing, unthawing, letting them grow, freezing again. And so it's a little bit more difficult, egg freezing versus embryos. However, women have more options now than they used to. This egg freezing has really helped women who do desire to be professional or to go to additional school or to work on their career, or they just haven't found the right person yet. The egg freezing gives them options of fertility, potentially longer than they would have otherwise. And so I think if you have the opportunity to freeze your eggs and you're not in a place where you feel like you would start trying for pregnancy in the immediate near future, I would look into it. I don't think there's an age cutoff. Um, let's see. I'm going to look through a few more questions here. We're um, almost done with our visit. Again, I appreciate you guys meeting with me for the last hour to talk about endometriosis and fertility. Again, this is a very sensitive subject, and I want to address that. Women are much more than just vessels for carrying pregnancy. You are much more than that. However, if this is your goal for fertility, I want to help you get there. I will help hold your hand through this journey. Fertility is very difficult, even especially with endometriosis. It is not black and white, but it negatively affects the ovarian quality, your follicular count, the ovaries, the fallopian tubes. It can be very detrimental to fertility. So it's important to have a focused plan so that we can ultimately give you the best chances at meeting your goals. Here in the chat, there is a link that you can use. This link will get you scheduled with my front office staff. So this is not a direct visit with me. It's a visit with my front office staff. At that meeting and that meeting time, you will be able to give your insurance information and talk to her about scheduling. And then at that point, you'll get on my personal schedule. But I just want to make sure to clarify that this link that you're seeing in the chat is to meet with my front office staff and then ultimately get scheduled with me. Um, you know, fertility planning consults are limited, to ensure personal attention. If you have endometriosis and you're considering pregnancy now or in the future, please book your consultation today. The earlier, the better. I want to see you and help you protect your options. Thank you for meeting with me for this last hour. I am honored that you gave me your time. This will be recorded and we will try to get this out for you to be able to access it. But this is very dear to me and close to my heart as far as how fertility, can affect endometriosis and how it affects women in so many ways. And I appreciate you spending the time with me to learn a little bit more about it today. Again, use the link in the chat to schedule a visit with my front office staff. It's not with me directly, it's with my front office staff, and then they'll get you scheduled to meet with me. But I appreciate you guys and spending this last hour with me. Sometimes I go off on a tangent, especially when it comes to endometriosis. I could talk about this all day, but I appreciate your time and hopefully you learned a little bit about, the fertility aspect of endometriosis and how it negatively affects all of these steps. Anyways, y'all have a great rest of your Wednesday. We will have another webinar next month, and I look forward to seeing you all. Hope you have a good day.